Thank you for joining us for our last OTAC clinical case webinar for 2023, but fear not, we will be back in 2024, of course. For this final session, we thought it would be quite apt, considering we've got a long holiday period coming up, to talk about planning for that holiday period, both as a prescriber, as many of you are who are joining us this evening, and for clients that may be looking to go away, as well as provisions for unexpected leave. And I'm delighted to let you know that Professor Paul Haber, who is the head of the Specialty of Addiction Medicine at the University of Sydney and a senior staff specialist and director at Drug Health Services SLHD, will be presenting this presentation. And Paul's also the clinical lead for the OTAC program as well. But before I go any further, I would like to make an acknowledgement of country and to acknowledge and pay respects to the traditional custodians of the lands on which we are all meeting this evening. And I would like to extend that recognition to any Aboriginal or Torres Strait Islander peoples who are present. Before we do get into it, I just wanted to very briefly announce an exciting initiative which we have launched recently with the Ministry of Health under the OTAC banner, and that's branded as the OTAC Scholarships. So what these are, they're sort of very specific scholarships, mainly targeted towards unaccredited general practitioners and nurse practitioners who are working in private general practice work settings. Whilst it is open to all applicants across New South Wales, there is a priority given to regional and rural people who fit within that scope. From now until the end of 2024, there are 15 scholarships. 3 are provided per quarter, roughly, of up to $2,000 upon completion of different accreditation milestones. So this includes, completing the course, doing the clinical placement, becoming accredited and actually prescribing. And the first round of applications closes next Monday on the 11th of December. So some of you may be accredited, but you may very well know a general practitioner or a nurse practitioner who is unaccredited or maybe mulling about, getting into opioid treatment prescribing. So I would very much encourage you to disseminate this throughout your networks, and we'll flick an email just after this webinar to provide additional information on that. Just very briefly looking at our registrations, I think at last check a few minutes ago was at about 65. So we've got about 20 people online. It's usually, about half people who register attend, which is pretty normal. And we've got a bit of a spread across rural and metro areas of New South Wales. And most people who are registered, interestingly, general practitioners are representing the largest cohort who are with us today. That number is slightly outdated because I updated that around 1 p.m. today. So we had 4 more registrations since then. And just very briefly, we've gone over these webinars, but we try and use this as a benefit many times before, but we very much encourage you to ask questions as we go and interact with the case studies. The sessions are, of course, recorded, and we do give you a certificate of completion for CBD at the end. CPD, not CBD, apologies, and so forth. If you are able to put yourself on mute, unless you're speaking or asking a question, that would be greatly appreciated. It really helps if you can introduce yourself as well. Tell us about yourself, what part of the state you're coming from, and so forth. And just very briefly, here are the sort of learning objectives that we'll be discussing this evening. I won't go over these in huge detail, as you can definitely see them there. But without further ado, I think I will hand over to Paul from here, who will take you over some of the cases and discussions. Thanks, Paul.
Hi, Dan. Thanks for the introduction, and thanks for logging in for this session. I'm just going to now share my screen and click on case 1. So you're a GP in regional New South Wales. You're planning a 4-week holiday overseas. Very nice. For family reunion and international conference. You prescribe opiate agonist treatment for 8 patients in your area, along with your other patient workload. Most of your OAT patients are low risk and are receiving takeaways. However, one has recently returned to using illicit oxycodone after his mother passed away. You have arranged a locum whilst away. However, they have seldom prescribed OAT, and there were no other experienced locums available in your area. So, first question is, do you need to inform New South Wales Health Pharmaceutical Regulatory Unit, or PRU, of your upcoming leave? So this is a simple question with a simple yes/no answer, and I invite you to click on the yes/no answer. So I'm going to click on my answer, and how many others? Polls submitted.
And
how many people have responded?
About 80%. I'll share those results now quickly.
Oh, great. So basically, the majority of people have said, yes, you need to inform PRU, and that's correct. So the guidelines do require that you inform PRU. They suggest you can do so by fax, but you can do, if you look at the guidelines, that's what it says, but you can do so by email. And I guess my first question is, how many of you actually do this? And I'm not asking you to actually confess to this grievous felony in front of all of your esteemed colleagues, but I think let me say this: why do you think the PRU has a reasonable expectation that they are informed that you're away for a month? Does anyone wish to comment? Take themselves off mute? Is it just that they're fussy and want lots of emails, or do you think there's a valid reason? I can see Frank McLeod on silent. Is he able to give us an answer? It's not that hard. Oh, Frank, you're there. Thank you. But you're still registered as being on mute, according to us. Can you come off mute?
Yeah, I'm off it now, I think. Yeah, I was just hiding my light under a bushel, Paul, that's all. Yeah, I think they've got it right, because 4 weeks is a substantial time. I think a couple of days, maybe you don't do much about it. But a lot can happen in 4 weeks, even with 8 patients, most of whom are low risk. And if something goes wrong, and of course it will go wrong when no one's available, without the PRU's backup through the system and the local health area drug and alcohol service, I think those people could be, up the creek without a paddle.
And what can happen, I think, is that one of your patients, the script runs out, or a clinical change, they request a different script. You have a locum. That locum then writes a revised script, sends that to the chemist. The chemist says, hang on a minute, I never heard of this guy or this lady, and either rejects the script, which can cause a great deal of distress for the client, the patient, or reports it to PRU. So you wind up with all these people sending each other emails and messages fruitlessly when you've actually appointed a locum who is actually available and doing their job to support the patients. But this treatment program is more than just the doctor and the patient. It's also the pharmacy and the regulator, and if they don't all know what's going on, they won't support the program. So that's what we say. It's a hard yes, and thank you for your comment, Frank, and I agree. And so I think I can just click on the next one. Now, can everyone see my screen still? Is that, yeah, great. So what key details need to be arranged and discussed prior to going on leave? So do we, so Frank's made a couple of comments, but you want to arrange locum cover if you can, with an accredited prescriber if you can, but in some parts of the state, there may not be an accredited prescriber. available, and you would have to get a locum as best as you can. And what if there's nobody? So occasionally we are asked in the local public sector to provide a locum support for people who've gone away. And we've had cases where either the pharmacist or the patient are in a tizzy because no locum was appointed, nobody can contact the doctor, and nobody knows what to do with the patient. And we occasionally provide a sort of ad hoc locum arrangement. So we kind of write the script for something, and it's quite time consuming because we don't know the patient, we don't know the script, we have to get a copy of this and a copy of that. But at the end of the day, we can do it. And it's much easier for the patient. And the patient is, of course, anxious, distressed, and often kept waiting for a day or more while all of this is going on. Frank?
Yeah, Paul, what's your thoughts on using telehealth in that sort of circumstances?
Well, I think particularly in regional areas, particularly if there's a specific reason to do telehealth, then absolutely. I think the less you know about the patient, the more appropriate it is to see them face to face, even if not for terribly long. But I think telehealth is reasonable. I know very well that there are some Medicare issues about telehealth in different settings, and I'm not providing a Medicare opinion, but a clinical opinion. So that may, and of course, I know you're from the South Coast, and so I know you're particularly likely to be in a situation where the patient, the pharmacist, and yourself are separated by 100 kilometres from each other or more.
Well, I've actually been 100% telehealth since the epidemic started, and I've now got patients from all over New South Wales, Broken Hill, Dubbo, Wagga, up and down the coast, and a couple of interstate and a couple in the ACT. And on a personal note, most of those I kicked off face-to-face, but a lot of them I didn't. And I also inherited a number after a couple of big-time prescribers in the local area were forced or decided to withdraw. So I've got a lot of patients that I haven't met, but I think using the video, I think, given that, you know, admittedly you don't have the ability to do physical examinations and that sort of thing, you get a pretty good idea. I've really found it very satisfying and really uncomplicated. And at the moment, I've got 232 patients, I think.
Well, you're collecting them.
Not intentionally, Paul, not intentionally.
Lucy?
Hi, I'm Lucy. I'm one of the nurse practitioners. Can I ask, Frank, what medium do you use for your telehealth? Is it Zoom or? No. I started to use Skype, and then one of my patients pointed out it had a huge security problem in which he could see everyone I'd been talking to. So I got rid of that, and I use a paid thing that's an Australian product, and it's through your browser called GP Consult. It costs $20 a month. You send the patient an SMS, they click the link, and away you go. Okay. Hopefully there's an NP consult somewhere.
Yeah. Well, talk to them. I wouldn't be surprised.
Oh, thanks.
There's a number of, for telehealth, there's a range of platforms, and that's a good one. In the hospital, we often just use FaceTime, just a regular phone call, but turning on the camera at both ends.
Paul, I think I've also seen some PHNs supporting local GPs to provide that sort of service as well. So have a chat to your local PHN. I think I've seen a couple do that since the pandemic.
And there's Zoom and Teams, the sorts of things that we use for meetings. It depends, on your patient. Some of your patients are very, know 5 times as much about computers as we'll ever know, and others not so. So just going through this process for going away, you've arranged a locum cover. I hope you have. You've informed PRU about the absence in the cover, which could be email or fax. you make sure that the scripts that you have for your patients cover the time you're away. So in other words, it's great to plan your leave in adequate time so you can do that. So you know, mindfully ensure that your scripts don't run out while you're away. Now, that's just an extra level of complexity now that we've got the S100 PBS things, but you can write an extra month. And also PBS, I had a patient just last week, and I've done this many times before, where their prescription will run out. This was an OxyContin patient with major chronic pain, where the script would run out while I'm on my holidays. In this case, the patient was not going away. So I had to get an early script for the patient, and the lady on the phone accepts that I'm going away and the script will expire while I'm away if I don't get an extra script. And they will always, well, in my experience, always will allow that script. But again, you have to keep track, because if I've got a patient that normally expires towards the end of the month, you know, December, that means over Christmas, I write a script in mid-December. The patient, the pharmacist, and me all have to agree that that new script doesn't expire on the 15th of January. It expires at the end of January because the previous script covers those extra couple of weeks. And it becomes quite finicky. It's not rocket science, but you have to keep track. And you have to also communicate with the patient so the patient understands that you have covered him or her till a certain date, whatever that date is, and that they agree and accept that. And getting them to agree and accept that, I think, is an important part of it all, because it is always confusing. There's no question about that. And then so you've done that, you provide contact details of pharmacist, patient, and clinic, so the patient knows what to do and the patient knows who the locum is. Obviously, in larger medical practices, hopefully it's another doctor inside the same practice who can access records and has the same phone number for the patient to contact, but sometimes not. And for complex patients, make sure there's a structured handover. And that can be very helpful. Patients who are, for the sake of argument, also taking benzodiazepines or who are not terribly stable, so that the person on the receiving end is not a hospital pass, but, as they say, but understands what's happening. If you've got 8 patients, you really ought to be able to do that, like in this case study we're talking about. But Dr. McLeod told us he's got 235?
32.
232. So clearly taking a holiday is a complicated thing. So Frank, what do you do when you take a holiday?
Well, I'm semi-retired, as you hardly surprising, I guess, but I basically don't travel. My wife and I don't travel, so I just carry my phone. In fact, I have not ever engaged formally a locum. You know, I've covered a colleague for a couple of days. He's covered me, like if short-term hospital admission, say, for some procedure. But that's about it. I really haven't had to face that. You know, in the future, I'm lucky in that Ian Shossaber's just moved into the area, and you know, we've got a professional relationship, and he's aware of my situation. And I tell all my patients, you know, I can't guarantee my age that I'll be there tomorrow, so we've got to have a parachute arranged, and Ian, I hopefully will be part of my escape route or safety net for my patients.
Yeah, I think it's good that you're starting to build that relationship with Ian, but clearly you've got to be able to take a holiday and get away and, you know, put the phone deep in a bucket under a kilogram of sand from time to time.
I just get out the back and play with the tractor, Paul. You know, I do all right.
Okay. Well, you know, everyone can make their own decisions like that. Of course, I wouldn't be, but you're entitled. Now, let's say, just as a variant on this kind of case, you're a GP now with unplanned leave. which does happen, a death in your family, or whatever it might be, are there any additional actions to complete? Would anyone like to comment on that? So we talked about the process of planning the leave, about all the steps that you do. Now, and I'm afraid we tear that all up because we've just said you're taking leave without planning, and everyone's got themselves on silent. I'm going to try and... Can I just pick on someone? Can I just pick on Wayne Zulueta? And I apologize for presumably saying your name wrong, but is Wayne able to take himself off mute and comment about if I had to take unexpected leave, what additional actions would I have to complete?
Hi, Paul. How are you going? I'm actually a pharmacist. Just logging in just to hear the thoughts on what happened over the Christmas period. Well,
all the better, because you're on the receiving end of this stuff. So what do you wish the doctor did?
It's a difficult situation, I guess, but I guess similar to what Dr. Frank mentioned about maybe having a possible backup in that situation.
I think so, because having said that we're going to plan the end date of all these scripts, so we're sort of planning or working up to taking our month off for even a month or more beforehand. Now we're taking that leave, we haven't done any of that. So I think we can say for sure that scripts are going to run out while we're away. So,
well, I don't mean to keep sticking my nose in, but I'm facing that situation right at this moment, and I'm going through all of my patients and giving them what I'm calling the parachute when the Frank McLeod plane crashes, and also when the Frank McLeod plane lands, which will probably be next September when I retire. And so I'm now giving them a protocol to follow that I've discussed with Illawarra Drug and Alcohol and also the PRU, and everyone seems to think, well, in the circumstances, that's the best thing. So I can summarise that if you'd like.
Yes, please do.
So the first step is I send them to their nearest public clinic or drug and alcohol centre, and I ask them to tell the centre 5 things: who they are, where they're dosing, what they're on, the end date of their script, if they can possibly identify it, and of course all their contact details. Now, the end date of their script determines their position on the action list as to how soon someone will have to step in and extend the script. So that's when the plane crashes, that's the parachute. On the other side, I give them an idea of what happens when I'm intending to retire. So I've given them 10 months notice, and we're trying to do let's seduce some of the GPs to get involved with the 10 methadone or 20 Suboxone patients they can take on without doing the OTAC. And the idea being that I'll hold their hand, I'll give them all the support through the rules, the paperwork, the whole thing, to just grease the wheels and facilitate the transfer. So I'm doing it currently at every patient I'm seeing until I've done through the whole lot, because 2024 for me is going to be a year of change. And of course, as I said before, at my age, I can't guarantee I'm going to be there tomorrow. So,
well, Frank, none of us can guarantee we'll be there tomorrow. And in a sense, that's a little bit about why we are having this session. And appreciate your planning. And I think what's really, really valuable about what you've just told us is that you're planning, almost a year in advance. And you've got quite a large number of patients, and you're in a regional area, which is an added degree of difficulty. So it's really great that you're doing that. But I'm just hoping that others are picking up on your comments and learning about it, because I think first of all, there's no perfect solution to this, but that's about as good as you're going to get. I think the key thing in this scenario that's on the screen is about unexpected leave. So Frank is planning, and that's great, but any one of us can get carried away on a temporary basis. And I'm not talking about if we drop dead, because that's something else. But if we have to take a period of leave and we're going to come back, I think the additional actions to complete are about communication between pharmacists, patients, the admin of your practice and colleagues to say, look, I'm having to go at short notice. I have not been able to plan my 25 patients or 125 patients in the way that I would have liked, and I'm sorry about that. And there's a fair chance that there's going to be some problems. There are limits to how well you can plan when you are effectively saying you can't plan. So let's look at case 2. Does anyone have any additional comment about that, or we move on? Okay, we're moving on.
I think, Paul, sorry to butt in. I think one of the other things that is important is to write clear medical notes at all times. I work in a group practice, so that is something that we use as clinical handover. So if I drop dead tomorrow, there's a record of clinical handover within the notes itself. So each patient has a clear, particularly for those complex patients, there is as you say, a structured approach, which is within the clinical notes. It's easy for someone who may not have any interest in prescribing can pick up the pieces. And so, yeah, that's probably how I would do that. So bed it into the practice rather than have it, so that all unexpected leave is accounted for.
I think that's very useful comment as well, because if others can read your notes but there's nothing in them, then that's a problem. And indeed, part of the guidelines refers to the notes having a clinical assessment, a justification for the treatment plan, a plan, and if there's a particular need to go outside the standard guidelines, then a documentation of what that reason is. You know, guy lives 200 miles away. We have to give him more takeaways. I believe it's not a particularly high risk thing to do, but it is outside the guidelines, so I'm going to do it. So I think good record keeping is important, whether you're going on leave or whether you're not. But I think it's particularly important where the opportunity is there. So thank you. Scenario 2. This is Kylie, 36-year-old, client who commenced on sublingual buprenorphine naloxone 3 months ago at your practice, currently 16 milligrams per day with no takeaways. Her recent urine drug screen returns positive for benzodiazepines, which you do not prescribe, and buprenorphine, which you do. Her partner has planned a holiday for them next month to go to Bali in Indonesia for 10 days. Kylie would like to go on this trip and ask how can she continue her treatment whilst on holidays. I think this is a particularly common at this time of year. So should Kylie be recommended, I can't see my screen, should Kylie be recommended to travel overseas whilst under sublingual buprenorphine naloxone? Yes or no? And would Kylie's use of benzodiazepines, as shown on the urine drug screen, exclude her from travelling overseas? Will you support her, do whatever you're supposed to do for her overseas travel if her urine is positive for benzos? So we've got, what's that say? We've got
about 50% have participated so far, so we'll give it a few more seconds. Yeah.
Tick tock, tick tock, tick tock.
And I might end it there just for
to move things along. Okay,
move
thanks.
things along.
So we're saying, should Kylie be recommended to travel overseas? Just under 40% said yes, 50% said no, and 13% were not sure. And the question about the benzodiazepines, basically, only one person said yes. Yes, sorry, I scrolled down. Nearly everybody said no. A couple were also unsure about that one. Maybe I'm a bit more generous than 50% of the colleagues online, but about a third to a half of opiate treatment patients are going to be positive for benzodiazepines. And in most cases, it's not prescribed. In some cases, it is. Sometimes we prescribe very small amounts and they're taking slightly larger amounts. So it's something that's very hard to regulate. I think I would be guided more by the person's clinical presentation than by anything else. So, David Helliwell has raised his hand.
I have. I mean, this might be a wonderful opportunity for a little bridging treatment with Buvidal.
I think that's a good point. So,
if you're unsure about the stability of her or the suitability for 10 takeaways, if you're happy, fine. But if you're not, you've got a plan B or a possible plan B.
Yeah, so I would be guided by my clinical assessment of this, of Kylie. Is she a disaster case that presents irregularly, is intoxicated, behavioural difficulties, child protection concerns, a whole gamut of problems? Or is she pretty steady customer who takes a sleeping tablet at night, or perhaps a couple of them, but who is, generally speaking, well presented, is not going to get herself into trouble? And if
I would agree wholeheartedly, Paul, with that assessment. That it's only if we're feeling a little uncomfy that I think that Buvidal might crop up.
But I think transfer onto Buvidal is a good idea. We have William has put his hand up.
Oh, just gonna comment. I'm not even sure that you can take buprenorphine naloxone into Bali. Like, they have pretty harsh drug laws, so I don't know if that's even possible. So I would agree that transfer to Buvidal is a good idea.
Yeah. So thank you for that. So I'll come back to that in a moment. But you're asking a good point. Is that particular form of treatment permitted? Would Kylie's use of benzodiazepines exclude her from travelling overseas? The majority of people, I think, said, the majority of people said it would be okay for her to travel overseas. One person said yes. So I think we'd go with the majority. If she's clinically okay, we would permit that. So I'm trying to end poll. I'm trying to get rid of this. How do I?
Oh, this one's just another poll, which David actually probably cut us to the chase with, but discussing.
Can we get this off my screen? I'm trying to show my slides.
Sure. There we are.
Okay, it's not on. It's still on my screen. Can people see the slides, or are they looking at the poll?
We can see the slides. We can't see the poll. Yeah.
Okay. So these are the treatment options. Now, the key thing when people are traveling, whether it's Bali or anywhere else, is to look at the local regulations. And there's an INDRO website, which is...
I've just attached the link specifically for Indonesia as well.
Yeah. So firstly, the website is generally useful. It is not entirely accurate and up to date. But let's look at what it says for Indonesia. Methadone buprenorphine. Can you see my shared screen here?
Yes. Yes.
Okay. Methadone buprenorphine treatment is available, importation is possible, you're allowed to bring basically a month of medication, must carrying scripts and things. So the answer to that question, and this was updated 4 or 5 years ago. So the answer to that is, at least 4 or 5 years ago, it was allowed. It's recommended that you contact the embassy and do whatever paperwork's required. In practice, the most important thing to do is that people take medication for their period of travel, and that it is, I always say it's important that the medication be in pharmacy issued packages with the proper name of the patient, the prescriber, and the pharmacy on it, which is the regular label from a pharmacy, so that, and that you don't tamper with it. You'd be surprised how many people will get the medication from the pharmacist in that format, but then they'll, when they're packing for overseas, they'll rip open the packets and they'll put it in something. And that actually introduces a problem that wasn't there. And so ask them to please don't tamper with the packets. Secondly, they should have a letter, should have a letterhead, it should have a contact information, and it should indicate what is being prescribed and ideally the amount. So, you know, Joe Blow is traveling from the first to the something or other. They're on this medication. They're taking a supply for 15 days. Please contact me if you have any concerns. In my years of practice, I have not once had a contact from police or customs official about that, but that is the best way to do it. And the letter doesn't have to be a long case 2.5-page letter about the patient. It's just to say, patient X is a patient of mine, they're on this medication, they're traveling, they're carrying a supply for them, you know, with your signature and contact information. I don't think I can honestly say a patient of mine's even had to show that letter. So when they try and show their medication or their letter to the customs agents, they keep telling me that customs agents aren't interested. They're interested in the stuff that the patients are hiding, not in the stuff they're showing. So it is usually quite fine to provide the patient a script for up to a month of medication in this way. And if they're going to be traveling for more than a month, then they really need to have access to a local service, pharmacy or clinic. Now, our scripts are not valid in other countries. We're only licensed in Australia, and therefore they're going to need referral to a clinic. And the clinic, that should be arranged in advance, and patients will find that very difficult to do. So the longer you do that in advance and the more specific the referral and the more specific the letter, the better. And you may need to get advice from some of your colleagues. You know, I have a patient going to Germany. One of my colleagues lived in Germany for 2 years and he knows something. And, you know, you use your personal contacts to work out how to solve that problem. Transfer. So looking at these options now, you've got transfer to Phyceptone or methadone tablets. You've got remain on sublingual buprenorphine naloxone, your current treatment, transfer to depo-buprenorphine, Sublocade or Buvidal, or withdraw from treatment as she cannot continue her treatment while she's overseas, or something else. Can you guys please click on the options for that one? Okay, we're going to. Are we done?
Yes, had about 65% respond.
So you can see the majority said stay on. 70% said stay on current treatment, and 30% wanted to transfer her. So I think in part it's going to be related to her stability. in part, it's related to what does she want? Is she somebody that was thinking of converting to the depot buprenorphine anyway, or was she someone who was really quite resistant to that and really wants to stick on her current treatment? And I would note that the way we set this question up, she was only traveling for 10 days. So I have to admit, I would vote with the majority here myself. I would, unless there was some major barrier that is not on these slides, I would continue her sublingual buprenorphine for 10 days. But you couldn't say it's wrong to transfer her onto the depot. But if she's transferred to the depot, patients do sometimes take a little while to adjust to it. And then they're supposed to be trying to enjoy their holiday. And so I think it's a challenging option and definitely preferable to continue current treatment. Now, why was she daily dosing before? That's a good question. Yeah, so you know, there's comments in the chat, and I think it is fair to say that the details of why this patient was on the treatment in the way that she was clearly are important to working out what is the best option for her. And we can't go through every option today, except to say I recognise and agree that these are valid considerations. So, okay, so Kylie is open to trying different options to allow her to remain on treatment when we're going overseas. How can we plan? Well, I think we've answered that. Case scenario 3, which is our second last case, we've got to move on. An Aboriginal client from APY lands in remote South Australia is currently on 80 milligrams of methadone. He's getting 3 takeaways a week, smokes cannabis occasionally, otherwise no other substance use, and has been going well on treatment for the past year. At an appointment, he says he's traveling in 4 days' time for sorry business after a passing of a family member. He expects to be away for 6 weeks, and he asks how can he continue his treatment while he's away. Should he be allowed to travel interstate for sorry business whilst he's on methadone? We've got a yes/no answer for this one. And again, please, just to prove that you're awake and alive, please type in your answer. We'll count to 10. Okay, I think we'll stop it there because I think everyone's pretty clear. There's one person who says he or she's not sure, but everyone else says yes. So clearly, if he's on 80 milligrams of methadone, if we just stopped it abruptly, there would be a major reaction, and we're not going to do that. He has no desire to stop treatment. He's just got a desire to do his family business. So the answer, I think, would definitely be a solid yes on that one. And what are his options? So is this, Dan, is this another one? Is this a...
Yes, another poll.
Another poll. Excellent. So we've got options. My poll hasn't come up on the screen.
Oops, there we are.
It has now. Excellent. Thank you. So which are the options? You can select, you can prescribe methadone tablets for 6 weeks. You can transfer him to depot buprenorphine. You can stick with methadone liquid, which is his current treatment, and prescribe him 6 7s of 42 little bottles. Or you can transfer him to sublingual Suboxone, or you can maybe do something else. So I think our answers are a little bit split here. We've got 6 people saying methadone tablets. We've got 7 people saying methadone liquid. He should stay on it. That's the majority. And then we've got a couple of people suggesting buprenorphine, and somebody's saying something else. I wonder what something else is. Does anyone who's voting for something else want to speak up and tell us what they meant? Okay. So somewhere here we can ask Jimmy what he wants. His preference is to stay on methadone while he's away. So how can we plan to do that? So we haven't in the scenario told you where he's going and how far away from a chemist or a dosing point he will be. But there is a fair chance that he's going to be a long way from a chemist. If he's going to a chemist, you can send to, not going to a chemist, going to the vicinity of a chemist, you can write him a script and he can pick up there. He could pick up his exact same medication and takeaway regimen. But again, it depends not just how far he's going to be from the chemist and what his family plans are. So some discussion about those would be necessary. And dispensing 6 weeks worth of Viseptone tablets, I can't say it's my favorite option, but if he was going really remotely and if he was a person who was pretty stable and he was not in company of others who were unstable, it could be considered. But I have to admit, I would feel anxious and that was a risky thing to do. What do others think? Does anyone want to comment about that one?
I was under the understanding that the PAU and the guidelines suggest you take tablets when you're going away for prolonged periods. And I think the issue is with spillage, breakage of bottles, less so with plastic. But I think it's much easier to travel with tablets than a whole heap of little bottles, I think.
I agree, but so I think I gave you a clue that I didn't think it was much of an option when I said that he might travel with 42 little bottles, because that's not practical. We'll agree. So you've got an option of a local chemist or just prescribing and dispensing enough tablets for the trip. The problem with the latter is that if he's away for 1 more week, and these things are not always so precise, he'll run out. And so arranging a local chemist is a good option, because once you've identified that, if an extension is needed, that can be done. So
that's fine, Paul, except for interstate transfer. A lot of the states will not accept New South Wales scripts. South Australia's okay. Victoria's a pain in the ass. Queensland's horrible. Tasmania, forget it. It depends on where you go. Northern Territory, I haven't tested, but given how retrograde some of the things that are happening there, I would not be confident they'd accept the New South Wales script.
My understanding is that they're supposed to, that we are allowed to prescribe, but as you say, this is regulated and sometimes challenging. And so if that happens, you have to either refer them to a local service, and we have done that, taken a transfer and referred them to a local doctor and service, but that becomes quite hard to arrange and more practical to go with tablets. I agree. David Hellerwell's raised his hand again.
Again, yes.
Twice, David.
I mean, one of the options, obviously, is a hybrid model where you prescribe your Viseptone tablets, but you do stage supply. So they don't necessarily go with 6 weeks worth. They might go with 2 weeks worth and then touch base at a pharmacy and then, another 2 weeks as a way, again, I guess, of showing a degree of safety, duty of care, but still trying to meet the patient's needs.
Yeah, I like that idea. I do like that idea, but that's if there's a local chemist that you can click on to.
Yeah, if there's not a local chemist, then you probably are looking at Viseptone tablets.
I think you probably are. So it's good to hear these two seasoned, experienced prescribers. You can see that there's individual troubleshooting and problem solving along the way for each case. So last case, you are now a country GP in regional New South Wales looking to retire in the next 6 months. Doesn't sound like anyone we've been talking about yet. You currently prescribe for 40 patients who are on a range of pharmacotherapies. The GP taking over your practice is currently unaccredited and has little experience in prescribing OAT. They're not sure if they plan to become accredited. Do you need to inform New South Wales PRU of your upcoming plans for retirement? Yes, no, unsure. Is this another one with a...
Yes.
Okay. And
we've probably answered that first one from earlier discussion already. But...
And there's a second, do you need to inform and discuss with your local public drug and alcohol service of your upcoming plans for retirement?
I can say from personal experience, you get a lot of brownie points when you do.
Yeah. Speaking as someone on the receiving end of these sorts of issues, it's nice for us to have had an opportunity to plan and to identify whether there are 10 patients being losing their prescriber, 110 or 210. So, and it takes time for patients to distribute themselves. One of the points I've noticed in my experience is that if a doctor in a certain place has 200 patients, those patients come from all over the place. And if the doctor retires, it does not mean that that particular suburb has to continue prescribing for 200 and something patients, because those patients come from all over the place and they will distribute themselves amongst their local communities. And when they've been with a certain doctor for a long time, they've moved around a bit. They've stuck with that doctor, but the doctor may in fact be quite distant from where they now live and quite inconvenient, but they've just stuck with that doctor. So when that doctor retires, they don't want another doctor from the suburb where he or she lives. They want someone local to their current address. And so they do tend to distribute, and there's this sort of shock of 200 patients dumped on the local service. In my experience, it's never been as bad as we fear. So we're stopping this one, but you can see great majority said yes to both questions, and thank you very much for that. You have 40 patients. The GP taking over is not accredited. Can he take over prescribing for all your patients? Yes, no, or unsure. So the great majority are saying no.
And I'll end the poll there.
Yeah, end it there. Some people are unsure. So let's look at the rules. I'm sorry. Oh,
we didn't include a slide specifically on those rules.
We didn't put a slide on the rules. So Dan, tell us the rules.
Yes, I can tell you the rules. So all medical practitioners who are unaccredited, so those are people who have not completed the OTAC one-day training session, and then subsequently done a brief clinical placement and applied for accreditation. Within New South Wales, you can prescribe for up to 30 patients in total. That comprises 20 on buprenorphine pharmacotherapies and an additional 10 on methadone pharmacotherapies. Generally, those on methadone, in less exceptional circumstances, they should be stable and transferred into your care rather than inducted. If you do become accredited, though, you can prescribe for 200 to 300, depending on your scope of practice. And that will also include for nurse practitioners. So the main caveat is nurse practitioners can't prescribe unaccredited.
So thanks, Dan. So it's sort of a bit of a trick question. You've got 40 patients. So the answer is no, but the unaccredited GP can do 30, but only 10 methadone, 20 buprenorphine. So it depends on the exact proportions of the patients. So the prescribing GP can take over the majority of your patients if they're willing. And if they take over, let's say half, it absolutely makes it easier for everyone around. And once they get used to the prescribing, then they may be much more agreeable to take this on, particularly if in that community there is a shortage, which there is in most places. Frank?
Yeah, the other thing to mention is that any GP unaccredited can have up to 20 patients on Suboxone that they initiate.
Yes, thank you. Yes, they can initiate. Of course, in this case, the patients are already initiated, but absolutely, GPs can start. I can't say this is something that happens terribly often, and because if you are unfamiliar with OAT, you're not going to be particularly comfortable to prescribe buprenorphine. And if you are familiar with it and you're into that type of work, then quite obviously you're probably accredited. But those are the rules anyway. Now, so we've talked about planning to retire. I think we've covered this issue very nicely. So transferring patient to another state, here are the contact information for the different sites that you can. These are in the guidelines, so at the back. And resources, the Indro Travel Guide is a useful thing, and the Opiate Treatment Program website. If you just type New South Wales Opiate Treatment Program or OTP, it comes up, and it's got all of these issues in subheadings and links and so on. And so, and the opiate treatment guidelines, if you've lost them, again, you can Google them and you can read them online. What a prescriber should indicate in it to whom it, yes, well, I've covered this, but I think restate it. Your letterhead, date, patient details, prescriber details, travel dates, summary of the relevant, brief history, but most importantly, the names of the medications, the dose and the quantity supplied. And all of what we've talked about is covered in the guidelines, one place or another, and you are always able to pull them up. Most of what we've talked about today is covered in those sections towards the back of the guidelines. As previously, there are supports for people in practice. Keep in mind your local AOD service can assist. DASAS is a 24/7 service, particularly designed to be useful for people in regional areas, but also in Sydney metro areas that don't have good specialist support. And it's 24/7. And also SafeScript is worth noting because it's now just about, maybe it's about a month, that SafeScript has upgraded itself so that you can use it to apply for to get an authority for a patient to discontinue and to change, and that's very useful additional functionalities. And its existing functionality about keeping track of patients' S8 drug use and dispensing through pharmacies are also invaluable in practice. So thank you. And if there's any last comments, you're welcome, but otherwise we'll close off today. You can, just as a reminder, we will be returning in February with next year. We're going to cover the changes to SafeScript in more detail, custodial health, and a range of other topics as we go through the year. We welcome your feedback, and if you think we've either said something wrong or if there's an important topic that you wish we covered, by all means let us know. And you can, through our website, log in and look at past webinars if you missed and want to catch up on them. So thank you all. Thanks for your participation through the year and for tonight. Thank you, Dan, for doing a lot of work on organising them. and we look forward to seeing you after you've had a nice summer break and holiday and enjoyed your time away, and we look forward to seeing you next year, commencing in February. Good night.